Hello, thank you so much for having us here and for putting this amazing conference off. I'm very happy to be here. I'm so excited to present my case. It's been on my mind for like 15, 18 months now. I will present this lady who's a 56-year-old lady. She complained of headaches of 4 years duration. She had severely debilitating headache that she required at least 4 grams of paracetamol and 1,200 milligrams of ibuprofen, plus other gabapentin, pregabalin every day for 3 to 4 years. And finally, when she presented to my clinic, actually she was referred to me as a case of sinusitis because someone at the end decided to do an MRI and they found sphenoid sinusitis. And this is the image that she presented with. So this is the MRI, and something is really off here. There is an isolated white-sided lateral sphenoid disease, which is in continuity with the brain. Just tickled my brain. I had to investigate more. So my first take-home message: never read a radiology report. Just read the scans yourself. After that, I decided to do a CT scan. A thin-cut CT scan, which identified a right-sided lateral sphenoid sinus defect of 7 millimeters, and that's the coronal CT. And as you can see here, that's the isolated disease. So again, isolated diseases either in maxillary sinus or sphenoid sinus, frontal sinus, should always make you think of something other than the usual sinusitis. So I decided to send the patient first to a neurosurgeon to investigate if there is. She had no history of trauma, so I had to investigate. This would be a weird thing to present with at age 56 as a congenital defect. We know this term is, I would say, a common side of CSF leaks and defects, but in this case, she's a 56-year-old. She only had hypertension, no other diseases, and she's been visiting many doctors in the past 3 to 4 years just for her headaches. So I decided to send to a neurosurgeon who did an LP, which was an opening pressure normal, and he actually told her that you don't need surgery, you just need a pill and maybe everything will go away. And that pill would be Diamox. So he did an LP, he took so much of fluid, she had severe postural low intracranial pressure headaches, and that she had to go to the ED because we suspected some sort of meningitis. And then he decided to maybe take the patient to the theater himself. I decided to take her to theater, so we did the surgery completely endoscopically. That's a wide sphenoidotomy. You can see that's the mass. If you really focus at it, you'll see the pulsation of the brain. So actually, I wasn't really clear with the history. She had headaches, but when I asked, after I saw the CT scan, she had intermittent CSF leaks, right-sided, clear, right area, but was never investigated. I couldn't collect any fluids, and in Jordan, we don't have it, like we have to send it outside, and it takes 2 to 3 weeks, and it's costly, so we don't do it routinely. So that's the surgery. First off, I started with the bipolar. I didn't think it was very efficient, so I went using the ablation. So the ablation itself was so traumatic, so it opened the cyst, and we had a significant CSF leak as we see. So I think using the ablator with the angle, but with the chloride mode was much better, much more effective. And usually in encephalocele or meningoencephalocele, you need to reduce the brain tissue and the meninges down to the defect, identify it, and make sure to reconstruct the defect, and that's what we try to do. Here I just did a rescue flap, I made it because I needed more room down there, and that's the bony defect. And then just with a ball probe, just identifying the edges to make sure that I'm going to put an inlay. So I decided to use polylactic acid, Redura, polylactic acid inlay graft. First of all, in cell-based surgery, in reconstruction, you need to remove all the mucosa to make sure not to have any mucoses in the future. And that's me just taking all the mucosa of the sphenoid sinus and then putting the synthetic dura material inlay under the bone. So I usually use a multi-layer approach. First, we start with an inlay. And then at this point, I did a Valsalva for like 2 minutes, and there was no CSF leak at that point. And then I just added, so the first part of the surgery was just taking down the middle turbinate. I took a free graft, and I just put it there. One thing I think you will all comment on this, I'll leave it to you. One thing, I wouldn't do the same way I did it. That's the graft. So you need to make sure that it's on top of bone, so you don't have any dead spaces. Okay, and then the gel foam, and then that's what I did, I think, wrong. I just put the fibrin glue on top of the gel foam, and it just got stuck for weeks after surgery. And I shouldn't have done that. I should have put it just on top of the mucosa itself and then the gel foam. That's it. That's what I did. But it's not over yet. But I'm very excited, or maybe curious, to know if you think this is enough or not. Just yes or no. We can continue the discussion later. I'm just happy to hear, is it a yes or no?
Well, this is a beautiful example of incident. I can't pronounce that English word, but something that has nothing to do with a headache. Huh? You don't get a headache from a meningeal encephaloceal, and this is just an incident. It's nice for her because otherwise, maybe if she had CZ leak, eventually she would get a meningitis. So it's nice that you already done her. I think what you did was perfectly. Well done.
Do you think the headache is not related to her?
Definitely not. I've seen numbers of these cases and they never have a headache.
Okay.
So if the headache has gone away, that happens quite often.
Yeah.
There's already a very old English saying, after the surgery they give you a present, after a year they want it back. And this would be an excellent example of usually the headache goes away after whatever you do. But it will come back. So the headache and the encephaloceal have nothing to do with each other. The surgery was beautifully done, I think, apart from what you recommended. Which can be very difficult. This one was quite easy because the sphenoid was not very extensive. They can be aware if you start to do these surgeries. If the sphenoid is very much extended to the left, it can be very difficult to reach that final last bit around sternal canal. And also, this is a normal age, where it usually happens. It's, although it's well, we don't know whether it's a birth defect or something which occurs, but it's usually, it's more of ladies, I think, and it's always in this age, and nothing to do with it.
Yeah, I very nice repair, no concerns. I agree, fibrin glucose on the graft, it doesn't go on the packing material. I actually, surprisingly, I almost always do a single layer on these, even one that's as big as this. I would just do a single layer mucosal graft, and it works. It does. It's amazing. It's amazing how well it works. I do more frequently as a septal flaps here than I used to, that's for sure. However, in this case, no problem at all with a free mucosal graft. My only little word to admonish you would be, I like, and I mentioned it yesterday, or earlier, today, I like to kind of paint this, oh no, I'm sorry, that's the course I was at. I like to paint the surface of the mucosa with a blue pen before I actually harvest the mucosa, because when I put it into position, oftentimes I'm looking at it with the endoscope and I can't tell whether it's the periosteal side or whether it's the mucosal side. So it's just a little trick, you know, just use a little ink pen on it when you harvest it so that you can always be sure 100%. Because I have had several mucoceles in my food, not my own, but other people have sent to me where it looks like it was inverted when it was put in there.
Okay, so can we continue? So the first, she was discharged second day, and the headache disappeared. Okay. Now the active issues she had in the early post-op period was very high blood pressure, uncontrollable, constipation for 10 days. So I was looking at the surgery, but not post-op, right? And she wasn't compliant with bed rest, and she was immobile, and she was taking forward. And she smoked. Okay, so I had multiple unfortunate events that worked against me. So that's her first week post-op. That's the endoscopic view. Any concerns? Looks okay, other than that gunk that I left in there with the glue on top of it. But there's no signs of infection, no signs of leak, no pulsations. So I was quite happy. And then 3 weeks post-op, she presented with this. That's her endoscopy. And you see the pulsations and the fluids. Is that CSF?
Yeah.
Yeah. Would you take her back to theater?
Yeah.
Sure. Thank you. Okay, so what would you do? So we all agree. Would you give her any chance for conservative management? Maybe these crusts come out, maybe some medications, anything?
Well, you know, what I saw, what you did was you put it in quite a big flap. And I'm always worried that if the flap is bigger than the part of the bone that you glued it, that it doesn't stick properly. So next time, I would make a much smaller flap.
Okay.
That only cover and really be sure that the bone is really clean and well, and the also the meningeal itself. I would have coagulated that more. I really like that part to be black, you know, to have a sort of crust there, because then the mucosa will attach better to that area. Because mucosa doesn't attach very well to dura. So you want some sort of fibrotic tissue to get there. So I think that was the reason, that, you know, that the flap was too big and the ends were loose, and then it came off. But well, bad luck.
So I actually go the opposite. I actually just strip more of that lining out of the sphenoid when I deal with these. Same idea, right? But I do a pretty decent sized flap, but it absolutely needs to be on raw bone. And I agree.
I denuded the mucosa well inside the sphenoid is where I pull most of the bulk of the graft. That's why I think I did.
So you know what? Another thing that I do a little different. I don't know if it makes a difference or not, but I actually use Mesa in these cabinets.
Yes.
Because it has a little bit more firmness to it, and that firmness persists for quite a while. Yeah, exactly. I always feel like it's giving me a little pressure against the repair, and I don't actually do any sort of debridement in these patients for the first 2 weeks or so after surgery. So I just let it sit in there, and I let them start using some saline in their nose so they get a little natural debridement. But frankly, at 2 weeks, I still see it there. I mean,
Yeah, you have to set it up, right?
I really do, but I think that's a good thing, and I think that does give us a little more pressure and hold that graft in position just a little bit better.
So,
but I mean, you know, again, she's stooping, straining, bending, she's smoking, doing everything bad. So I mean, she might as well just like stuck something in her nose and pull the graft out at the same time.
So this time, I decided to take her again to theater, but this time I had to do everything different. So I had to prepare for 1 week in advance. 2 nephrologists, 1 nephrologist and another cardiologist were on board regarding her blood pressure. That's the first thing. I had a diagnosis pre-op, 1 week pre-op, and intra-op at the beginning of surgery we inserted the lumbar tract. Okay, and this time I'm not sending her home. As soon that's the second surgery. Another surprise is that when I got in, I didn't find the leak. So what would you do in this case? I really didn't find anything. So after I cleaned that, it was really hard to take all that out. I'm never going to cook food without gel foam again. But there was no leak, and multiple balsava. I spent like 30 minutes just making sure that I do have a leak. What would you do?
Well, there is a leak.
There is a leak, but there wasn't any trouble. So
Yes, but that's a dural tear, you know, and the dura is sort of laying like two flaps on top of each other, and that stops and starts again.
So
and
she
stops
can
again. So very likely that at the moment of surgery, you know, the blood pressure is lower, and it's quite often you see the leak.
I did that maybe 6-7 times.
So redo it, just redo what you did.
Yes. So thank you. That's reassuring. So this time, yeah.
I would be a little different, and I actually probably wouldn't have.
Okay.
So I've seen, I mean, we all, I guess we've all seen this kind of thing happen, and you look at it in the clinic and say, oh, you go to the operating room and it looks like that. And I actually do think that some scar is forming and it's actually sealing over. And so I always feel it's better to give it a chance that way. And I have had a couple of occasions where I might put the drain in for a couple of days and just drain them and see what happens. But you know, you see this sometimes after pituitary cases and such as well. And I'm willing to give them a chance, and I think it can work. So. But I don't have a problem doing this either. This is good.
Yes. Please.
I don't know something that you could try also is before doing this and inject fluorescent intrathecally and then ask for some pulse.
I know where the leak is. Why would I know? Yeah, but I didn't expect not to have a leak. Yes, so I wasn't in question about the diagnosis. I went to prepare, but once I didn't see it.
No, but even then, you know, if you see pre-op, and it's quite often that during surgery it's much more difficult to find than you think. So we do the same. We usually do fluorescence anyway, also when we see the leak, just for two reasons. One, you see it during surgery much easier, and two, it's very easy to see whether it is watertight when you finish the surgery. So two reasons to do it anyway, even if you know where.
To double check on very clearly. So this time it's a nasoseptal flap and fa'aliyat by my colleague, Dr. Ahmad. I did a nasoseptal flap, as I was saying. I didn't have Colorado needle. That's how we struggle sometimes in Jordan, but I got my way. And that's the mucosa on top. So the polylactic acid that I inserted was completely intact, was very adamant. I really didn't know what happened because it was completely intact. There was no leak even with the only polylactic acid. So what I did, I stuffed another inlay fasciculata inside. Was too bulky. There was no room for it. I admit, but I just tucked it in.
You should have separated the dura of the bone a little bit more.
That's not dura, that's the re-dura, the polylactic
I
acid.
understand. The dura, the original dura with the bone. Then you will create a space to push it in.
Yeah, that's what I tried to do with the ball probe.
But the first
but it wasn't so much.
is using artificial material.
Oh.
I had the same experience. It was my professor's secretary, and I used this artificial material and it leaked again. So always use autogenous material in these cases.
So I was trying, because I knew I didn't have to put on multiple layers. And
You didn't want to spend much time for
Exactly.
getting the, I understand.
You have no idea how Jordanian patients are living with. So I had to use that. You always talk about Turkish patients. No, they can use simply.
The most important part of the operation is the first part, to put autogenous facial graft between the dura, because you can separate. It's not attached to the bone.
Would you take the previous one out, the polylactic acid that I did?
It doesn't matter, but
You can, it's very active. I would widen the defect, right?
it displays. So you have CSF leak.
Yes, exactly. Now I know. And then I put another onlay fascia left, and then the nasal flap, and this time I put the glue right on top of the mucosa flap. And again, I tried to do everything different than the first time. So gel foam and then Merced packing for 5 days. Yeah.
So can I have another recommendation?
Yes, please.
Instead of gel foam, you should put Surgicel. Surgicel creates granulation and fibrosis.
Yeah, that's why you put it at the edge, right?
Of course. And as
Yeah.
about the mucosa, not
She was trained to bed for 6 days. This time, she refused Foley's. She was about to cancel the surgery just because of Foley's. So I couldn't do strict bed rest. She had bathroom privileges and diagnosed for 2 weeks. And that's her 6-month postdoc. It worked.
because you put lumbar drain.
Maybe, no. Because
No,
of that.
because lumbar drain. The problem, the question is, why did she? What kind of headache she had?
She had right-sided pain, shoe
Because
pain.
I understand why. Because she has benign intracranial hypertension, and in these cases, this lady, obese lady, and at the ages of over 40, 60.
But immediate opening pressure was normal. But that would be expected because she was leaking. But at that point, when she came, she was leaking.
The issue is she was having headache, and when the CSF leaks, her
It's
headache
subtle.
was getting better.
Yeah, that's the only
So
explanation.
that's the most important
Yeah.
part. And you don't need to do lumbar puncture in these cases.
Yes.
But what you should do is shunt. You should put a shunt because the neurosurgeons make it to decrease the intracranial pressure on further.
So not surprisingly, I'm going to completely disagree with the Turkish patients. So shunts, in my experience, always fail, and they're always a problem. Now, admittedly, I'm an otolaryngologist, so I don't have to deal with those problems, and my neurosurgeon will deal with them. However, I can tell you that we're very shunt-phobic at my institution, and shunts will help you for a couple of weeks, but they'll almost always fail on you in the long term and cause you problems in the long term. So they're basically just passing the problem to the person who inherits the patient after they retire.
As always, I fully agree with Brent. And our neurosurgeons fully agree. Even if there is really high intracranial pressure, and I say, yeah, well, thank you very much, but she will leave again. The neurosurgeons say it's much better to close a few weeks in the rest of her life than to have a shunt and the chance of having meningitis and all sorts of disasters of a shunt. So my neurosurgeons also don't want to put a shunt for intracranial hypertension. But that was the reason for that, but it has nothing to do with the meningitis and secrecy. You want to add something? And then I go to microphone.
So one thing that's important to point out is your nasal flap. I might have, it's interesting that you had a good pedicle there at the second operation, because the truth is that when I do these operations, very commonly I bring that lid down pretty low, and I also often am in the pterygopalatine fossa in these cases, and I'm sacrificing the sphenopalatine artery on that side. So there's going to be lack of blood supply. So I'm impressed that you had blood supply. It's possible it was just a free graft essentially that you but there they have backup on it. It's possible, I guess. But the other thing I may have done differently. Yeah, it was a small.
I think I was lucky because the defect was in a place.
Yeah.
I didn't have to go really down to.
Gotcha. If you, and of course, if you really want to rely on that flap, if you really got concern, you could always do it from the opposite side.
Yes, exactly. That was sweet.
It's 10 past 5.
Finished?
I'm finished.
You are finished. I tell you you're finished.
I am finished. I just want to say a few words about whatever is happening in our world. It's really bad. We're witnessing this happening at this time. I just want to say that we are really privileged as doctors to practice the way medicine we are practicing. Doctors in Gaza, they don't have that privilege. They don't know they're sick. They work starved, and they don't know they're going to get detained or killed. They don't see their families. I think we are very privileged that we're able to practice medicine in this way, and they can't. It's really bad what's happening, and I hope it stops. I hope we, future generations and doctors, we're more oriented about what's happening and we just uphold the right side. Thank you so much.